are in listen-only mode.
Welcome to the ongoing Friday morning conference series sponsored by AHEC. You know, not only are those of you present here, but also there's 8 other sites around the state that are also tuning in, and we're very fortunate this morning to have Dr. Gary Willstein present to us the newest updates in orthopedic procedures, especially total hip arthroplasties. Dr. Willstein is probably familiar with most of you. He's been here since 2000, but before he got here, he was an undergraduate at Iowa State University and then med school at the University of Iowa College of Medicine. He did his orthopedics residency at West Virginia University. He practiced in Denver for about 10 years, and he was also an assistant professor there at the University of Colorado. He moved here in the year 2000, and that's when I first got to know him, and we've had some wonderful interactions over the years. I'm really thrilled to have him here. He's medical director of Providence Surgery Center and physician dyad of surgery here at St. Pat's. So Dr. Willstein. Oh, and by the way, anybody who does have a question, we'll ask you to use the mic so that people who are listening in from around the state also can hear the question. So thank you.
All right, thank you. So I think Robin asked me to give a presentation, emailed me, because I gave a seminar to patients about total hips a number of months ago, sometime this spring or summer, I can't remember, and somebody heard about it, so I figured I better doctor it up a little bit so I can present it to you. Because that was a pretty basic talk, specific about primarily one thing. But I thought there's been a lot, obviously, on marketing out there. There's been a lot of, ads about hip replacement and recalls and lawsuits and things, that come across the television. So I thought I'd start with where we started and where we are now. So a little bit of history and how we got to where we are now and what has worked and what hasn't, some catastrophic failures and some successes. Total hips, at least attempted, started in 1891. Hard to believe that it was that long ago, over 100 years ago. And Germany, a doc tried to use ivory to replace destroyed femoral heads from tuberculosis. That puttered along in 1925. A doc that, remember that name, Smith Peterson, tried to use a glass on a femoral head, but the glass would shatter. And just to give you an idea, at some point in the 50s, early 60s, in Austin, more hemi-arthroplasty, which is used for fractures for many years, a very basic hip replacement, somebody got the idea to put little transducers on the head and measure what kind of forces are transmitted through a hip joint. And this is probably way before IRBs were invented. So they put one in somebody or a few people, and just rolling over in bed was 3 times body weight transferred through your hip joint. And so you can see why a piece of glass would shatter when you tried to walk on it after a period of time. 1953 in England, Dr. McKee, and it was a McKee Ferrara prosthesis, developed a metal-on-metal bearing hip. It wasn't cemented in, it was just kind of screwed in. And it had some limited success, but wasn't adopted very well. And in the 1960s, started the modern hip by Dr. Sir John Charnley in England, and is truly figured it out in his garage type of total hip. And really, it's called a low-friction arthroplasty, and when you really look at things, it hasn't changed that much since the 60s. He was quite, forward-thinking, and some of his hips that he put in actually lasted 20 plus years, which is quite amazing, since most of our, up until the last few years, standard hips would last about 15 years is what we would tell patients. But he got 20 plus years, and if we could all duplicate what he did and true good studies, we would all be sitting pretty and probably wouldn't have changed much from where we started, even though we have changed some. So that's Charnley, and his big advances, and that's his hip. That's a Charnley hip. Was using acrylic cement as methyl methacrylate to fix the prosthesis to the bone, and it's immediate fixation, and it immediately the stresses get transferred to the bone through the trabeculate by that grout that the cement is into the bone. It's really not a glue, it's a grout. And it worked well. And he used high molecular weight polyethylene as a bearing surface. and that turned out to work well. The NIH has stated that total hip arthroplasty is one of the most successful surgeries that we do in the United States. When you look at patient outcome, the cost, its economic benefit to society, patients become less of a burden on society. If their hip is replaced, they become more productive again. So it's a very good thing when the NIH has looked at it in a societal role. Give you an idea, about 300,000 total hips are done per year now. They estimate by 2030 there will be about 500,000. It's a 174% increase. Compared to total knees, 450,000 done now, but by 2030, 3.48 million total knees. So we do many, many more total knees and hips, and that will continue. Just the nature of how we wear out, our knees wear out more commonly than our hips. Why do we do it? Primarily degenerative joint disease, rheumatoid arthritis and other inflammatory diseases, avascular necrosis, fractures or fracture non-unions or malunions, and we have various different types of prostheses or variations of prostheses depending on the fracture and tumor and where the tumor is. Pathologic fractures after the tumor is formed, the bone becomes weak. We'll replace hips sometimes. Congenital hip disease, dislocated hips in infancy that go on to cause problems as we become adults. Joint instability, that's pretty rare. And failure of other hip reconstructive surgery, things you hear about now, impingement, cam impingement, where we're starting to do hip arthroscopy to treat. That doesn't always work. The hip goes on to fail and become arthritic. So those are the indications. Components of a total hip. Basically, you have a stem. There are variations, many variations on a stem. They have a neck. There's a femoral head, a liner, which is the head and the liner become the bearing surfaces. We'll talk about that in a minute. And then an acetabular shell or cup that the liner fits into or snaps into. We saw Charlie, he just showed you that liner. They yesterday just used to cement the polyethylene into the bone before they came up with metal liners. And so this is a little older model of a hip, but just to give you an idea, just remember the size of that ball and the cup. We'll talk about that later too. So I talked to, as mentioned, that Charlie figured out the cement. It's polymethyl methacrylate. He stole it from the dentist. He didn't come up with it. And it's, as I said, it's grout, not glue, and it transfers forces into the bone through the tuberculate. And if you remember, bone reacts to the forces applied to it. If you remember your basic science, Wolff's Law it was called. And that's why bones heal. They like to heal under compression. And if you don't apply compressive force to bone, it disappears. And I'll talk about that a little later too. Well, the cement was a great idea, but hips eventually failed, and they would loosen from the bone. And scientists got in to figure out why they failed, and they thought it was the cement. They thought the cement was the weak link. And so they said, can we get away with not using cement? And they went to cementless designs. And they thought it would prevent loosening and what's called osteolysis, where the bone resorbs away from the prosthesis. And they put it in thinking this is going to be great, look good in the lab, but it's still, osteolysis and loosening still occurred. So they kind of threw them for a loop. They went back to the drawing board, but we have actually moved on and used cementless because there's still advantages to a cementless prosthesis. And the cementless prosthesis has a surface on it that the bone actually grows into. And it's a rough surface, and there's ingrowth and on-growth. It was first developed using cobalt chrome, but now most prostheses are titanium. The surface is titanium. And the coating to prevent that, and I'll talk about stress shielding in a minute, but that coating that the bone goes into is usually proximal, high up on the stem, and surrounds the entire cup, but high up on the stem. And when we put these in, the initial fixation, why we can allow these patients to weight bear right away, Why can we do that? Because the bone doesn't grow in a day. It takes about 6 weeks, just like a fracture heals. It takes about 6 weeks for the bone to heal to the prosthesis and for initial fixation of that healing. But it's a square peg in a round hole. We're kind of jam fitting that prosthesis in. When we put the cup in, we use a hemispherical cheese grater to roughen the bone, make the bone bleed. That stimulates healing. And we might ream for say an average sized woman, we might ream to 51 millimeters diameter with our reamer. We start small, maybe at 45, and we ream up to 51 millimeters, and then we jam fit a 52 millimeter cup in. And it's, that's the orthopedic strong as ox and twice as smart. That's what we're using that mallet and pounding that prosthesis in place. So that's our initial fixation. It's easier to easier to revise in a cemented hip. There still can be very difficult to pull one of these out, and we have to do that for various reasons. But we don't have to deal with chipping out the cement, which takes a long time and can be very difficult. It can cause a lot of bone destruction in the process. So I'll kind of hit on some of these things in a minute that I kind of glossed over, like osteolysis. So cemented fixation is a mechanical interlock. It's static. It doesn't change in time, and the fixation degrades. Cementless, you've got live osteocytes in there growing to the bone. The forces are continuing, so the body responds to that, and it's kind of a dynamic fixation. The bone's continuing to respond through the lifetime of the prosthesis to hold it in place. This is a cementless implant that has been retrieved. And you can see, it's not a great picture, but this is all bone that's still stuck to the prosthesis on the coating where the fixation occurs. I talked about the stress shielding and osteolysis. So the original designs of prosthesis, you can see a little better here. You can see the prosthesis is a little wider right here than down here. So that coating starts here and goes all the way up to the collar here. And this is when it was put in, and you see this nice bone, this nice cortical bone, everything looks great. You come here a few years later, and that bone is disappearing. And and you see a lot of denser bone down here. Well, that prosthesis fixated to the bone fixated to the prosthesis very well down here, but it was stress shielded. So you think about bearing your weight through your foot, up through your hip. It's transferring from the bone to the prosthesis here, and all this bone up here is stress shielded. It's not getting those forces applied, so the body's reacting and it's disappearing. So in order to avoid that, they figured this out. In order to avoid that, they just put that proximal coating. They put the coating more proximal, just at the top of the prosthesis rather than towards the bottom, and avoided that stress shield to a point. It still can happen. The other thing that happens when you get that fixation distally down here is people can get thigh pain. You have this very stiff metal prosthesis sticking into the thigh, and they can come down to about here on some of the older ones, the longer ones. And so, your bone bends a little and gives a little, and the prosthesis didn't. And so people would get thigh pain. They have this basically a stiff stick sticking inside the bone, and the body is bending around it. The bone's bending and would cause thigh pain. So the design of these prostheses has changed somewhat. They shorten, they get the proximal fixation, and they often taper at the distal portion instead of being solid to prevent that. Actually, another design is a clothespin design. That picture I showed you earlier had a clothespin design, so it would give a little as you walk and flex your hip. And so another view of that proximal stress shielding osteopenia, here it is initially, and here it is a few years later, and that bone is starting to disappear. It's disappearing away from the collar here. You can really see it there. And actually most prostheses now don't have a collar, because we don't use that collar to load the bone, load the weight of the bone. So collars are gone on most prostheses. So that was the stem design, and then when they figured out the stem design and they figured out cement's not the problem, they went back to the drawing board and they said, what's the problem? And the problem turned out that it's the polyethylene. And actually, Charlie first tried Teflon. It was too soft. It kind of creeped and moved and it would wear through. So Teflon didn't work. It's a nice smooth surface. And then he went to the polyethylene. Well, polyethylene is a gold standard for many years. It has about, total hips to use standard polyethylene have about a 15-year survivability on the average. Some people can get longer, some shorter. But what they found was as you use your hip, and it's about 1 million cycles a year. So when they test prostheses in the lab, they put them on a machine and they cycle it 1 million times, and that equals 1 year of walking for the average person. So as we cycle that hip and we walk on it, the plastic wears and little microscopic particles are formed. Well, those particles, the body tries, in layman's terms, tries to eat those particles up, sends in cells. They can't do anything. It's inert. You can't chew it up. Cytokines and proteolytic enzymes come in, are secreted, and macrophages come in, migrate in to the area, and instead of trying to chew up the plastic, it starts chewing up the bone and causes this osteolysis or aseptic loosening, no infection involved, and that's what the cement disease was. So it wasn't the cement, it was the plastic. And we made it worse by poor sterilization techniques. And what happens when they were sterilizing these, they were leaving oxygen in the sterilization atmosphere, various other impurities, and free radicals would form within the plastic as the plastic is being formed and being sterilized, and that causes more oxidation of the plastic, and the plastic breaks down even faster. So we've learned to sterilize better, but they said, well, how can we improve on our polyethylene so we don't get osteolysis? And here's an example of osteolysis. This is a cemented component, and you can see the bone resorbing away from the cement. We call them lucent lines around the prosthesis, and this is a Charnley prosthesis, or a variant of a Charnley. And even to the point where the bone becomes very weak and fractures. And here's a cemented design. You can see here that this plastic has worn, so this has been in for quite a while. Plastic's worn, the ball isn't centered in the socket anymore, so it's just kind of worn through the plastic. But it has formed lytic lesions around the prosthesis, even way down the shaft and around it. And so that prosthesis becomes loose, becomes painful, and because the cup has a problem, you can have instability as well. And that's how hips fail over time. So instead of plastic, metal on plastic, and that metal is cobalt chrome, the metal of the head, you can't use titanium. It wears. Titanium is very strong, but it's not good at a bearing surface. It will wear away. So the metal balls are cobalt chrome. It's like your bumper. It's a nice, strong, shiny, smooth surface. Doesn't wear very much. So because of that McCree Ferrar I talked about earlier, there's some historical data that said metal and metal may work. We thought, well, we have better metallurgy, and we have better manufacturing techniques to make those surfaces smoother and match better. Let's try this. And it looked great in the lab. There was a lot less wear, so very few particles. The particles were smaller, and actually 60-80% less particle wear than a standard polyethylene. And they said, this may last a patient's lifetime. Let's put it in patients. Looks great. Let's do it. Well, those are the ads from the lawyers. Metal on metal prostheses. And one thing we found with the larger heads, we can use larger femoral heads with metal on metal. And so when you have a larger femoral head, you can have lower dislocation rates. Dislocation is one of the risks of total hip. Patient flexes too far, turns their leg in too far, various things. The ball can pop out of the socket. It's a trip to the emergency room to pop it back in. Charnley started out using 22 millimeter heads. So to dislocate a hip, you have to go half the distance of the diameter of the head. You have to get to that jumping distance, and so 11 millimeters. It took 11 millimeters to pop that head out of the socket. He had very low, he had high dislocation rate, but because of on plastic, the small head would wear better, less wear. He eventually went up to 26 millimeters, and the standard for hips for many years was 28 millimeters. It was considered a good balance. So that jumping distance is now 14 millimeters. And so it was considered a good balance between wear and stability. With the metal heads, because of the physics, metal heads, you could go up to 40 millimeters. So now you've got your jumping distance at 20 millimeters and much more stable hip. I won't go into the physics of why you can go to bigger heads on metal, but it just say it would work better. You've got less wear with bigger heads on metal than smaller heads. Well, unfortunately, they said it didn't work, and the problem was patients were getting hypersensitivity reactions to the cobalt and chromium ions. It's still not fully understood what's happened, but they're getting osteolysis, just like on the poly on metal, on metal on poly hips. They would get additionally soft tissue reactions, and soft tissue loss. The gluteus muscles would start disappearing. You get into a total hip of one of these, and the gluteus maximus, not so much the maximus, but the gluteus medius, gluteus minimus was gone. And they couldn't explain why. And they had large fluid collections, these kind of pseudotumors, and it was all this hypersensitivity reaction. They don't consider it an allergic reaction, but a hypersensitivity to the metal. And this has been coined metallosis. If you didn't position the cup just right, and there's high wear on the edge of the cup, called edge loading, it would have these increased forces and wear, and they would fail catastrophically. Additionally, free radicals, these cobalt chromium ions, could be carcinogenic. It hasn't really been proven, but theoretically, you've got these free radicals floating around. You can measure cobalt chromium in the patient's bloodstream. It's one of the things we do when people are having issues with their hip, metal on metal hips, bearing surfaces, and they would build up in the liver sometimes. They saw, the livers are waste disposal area, and they would find high levels in the liver. And so there's concern for these free radicals. And the biggest thing with a lot of these lawsuits that you hear about, especially the DePuy, it's called the ASR, it was a design flaw somewhat by the manufacturer. The hip wasn't designed quite right to work well. So they had a recall when they saw there were problems, and that's started the lawsuits. And it came to the point in 2013, the FDA actually put out a warning on metal implants, bearing surfaces, and at that point, I think most surgeons stopped. So they really aren't done today in a general practice. So I would say most people aren't doing it. There may be a few out there still. So this is an example of metallosis. Here's a head, a large femoral head, and this dark material, that's the metal staining in the synovium. Here's an example, and this is what it looks like when we get in there. The fluid, when you aspirate the fluid or you open up a hip joint that has metallosis, the fluid's kind of this greenish gray color. You think, oh God, this is an infection maybe, but it's not. It looks a little purulent, but it's actually kind of watery, but has an ugly looking color to it. And the metal stains the tissues all around. You have to excise all that, because if you don't get rid of it, you continue to have a reaction. So if you revise one of these, you have to remove all this stained tissue, and it's a very tedious job sometimes. Another, in addition to metal on metal, it came out about the same time as ceramic on ceramic bearings. And the metal on metal and the ceramic on ceramic bearings we call hard bearings, or hard on hard bearings, instead of a metal on plastic. The plastic is quote soft compared to the metal on metal, or ceramic on ceramic. The ceramic material is zirconia or aluminum. It's very hard, it's inert, it's scratch resistant. It has a lower coefficient than even the metal on metal, lower amount of wear, and smaller particles. It's much more expensive. It has to be positioned, the cup and the surfaces, so when you have a ceramic on ceramic bearing, it has to be positioned just right, where you do get that edge loading again. And so if you put the cup into vertical and the ball is sitting in like this, and the cup should be about 40 degrees of inclination, angled about 40 degrees. If you put it into vertical, you can imagine the forces going against the corner of the cut, corner of the ceramic edge. That's called edge loading. And if you get edge loading, you can have considerable wear of even the ceramic. It can crack, it can fracture, and it can be catastrophically fatal. The other problem with metal or ceramic on ceramic, it can squeak. They really don't know why, but a patient will walk down, I mean, truly squeak like a door squeak. And you know, they'll walk in, think about every step you take, you squeak. And you can't fix it unless you go in and revise it. You can't grease it up. It doesn't happen often, but it can happen. Early designs, the ceramic could fracture. They had high fracture rates, and you'd have to revise those. And then because of just the manufacturing, the way they have to make these, it's a small head size, so you lose that bigger head size and make more stability with the ceramic on ceramic heads. So we do these. I used to do more of these, but with now newer plastic, newer polyethylene, which I'll explain in a minute, kind of gone away from these, the ceramic on ceramic. And just to give you an idea of where, you know, we talked about, it's really these particles, it's a problem. Standard polyethylene, the wear volume about 30 cubic millimeters per year in the average patient. Metal on metal, orders of magnitude smaller, 1.6, ceramic 1, so you can see why it was very attractive to go with this. The particle size, order of magnitude smaller. The 500 is if there's catastrophic wear, but the metal on metal and ceramic wear particles are small. And how many particles per billion per year? There were 500 billion particles per year average in polyethylene, so only 50,000 in metal on metal, and in ceramic on ceramic, only 1,000 to 10,000. So quite a bit different. So the new Cadillac, the new thing that we are putting in patients now is cross-linked polyethylene. It relatively fixes the problems with polyethylene wear. Polyethylene is formed, and then it's formed, and then they melt it down with gamma radiation or heat, pressure, or reform it, throwing in sulfur, and the polyethylene are long carbon fiber chains, and then they cross-link side to side these chains with sulfur molecules, and that makes the plastic much harder, much stronger, and significantly less wear. In the lab, they put it on the machines, put body weight to it, 1 million cycles per year, and certainly they can do that a lot faster. And they look at it 30 years later, and there's hardly any wear in the lab. It seems to last 30 plus years in the lab. The retrievals that they've done on patients who have died look like that it's going to pan out. You know, we haven't put them in for 30 years, so we can't say for sure in vivo that's the way it's going to be, but it does look like it's going to be that. They've learned to sterilize it better, so that the problem of sterilization isn't there, so lower free radicals. And they've come up with some interesting ways to do this to get these free radicals out. One way is some companies actually impregnate the plastic with vitamin E, which is an antioxidant you hear about all the time, making you healthier. Well, it scavenges the free radicals and less free radicals. There are other antioxidants they'll put in, or just the way it's formed, it has fewer free radicals. It can still fail if it's malaligned during implantation, and what's called third body wear. If you have a little piece of bone that gets between the ball and the socket, which isn't common, it can catastrophically break down and wear. Think of it like a piece of sand or a pebble in your shoe, how much that bothers you, rubs against your foot. Same idea, if a small particle gets between the ball and the socket, gets on the plastic, it can wear it down and destroy it. With the high molecular weight polyethylene cross-linked, or cross-linked polyethylene, you can still use large heads, so we have lower dislocation. Because the plastic doesn't wear, and the physics behind it, we can put in bigger heads with that plastic. Not quite as big as the metal on metal, but still larger heads than that 28 millimeter head. So today's total hip, best construction today, a titanium or titanium alloy stem. It's proximally coated for ingrowth up high. It's tapered down low. A titanium shell that has coating on it as well for ingrowth. a high molecular weight cross-linked polyethylene, and you can see how thin that liner is, where our plastic liner used to be much thicker, a large ceramic femoral head. We still use a ceramic on the ball because it's smoother. It will, again, lower the wear rate of a plastic, even on that high cross-linked plastic. So that's a standard new total hip. That being said, the ceramic's expensive. It's not that big a difference, so in a Medicare patient, we'll often still use a cobalt chrome head because it doesn't make a huge difference. Somebody under the age of 65 will often use ceramic. And they are pink. They're from the one company. They're either kind of yellow or pink. Nice pink. Get a nice pink hip. You hear about hip resurfacing, and that's big. And not as big as it used to be because it is a metal-on-metal component. And this is a hip resurfacing. And hip resurfacing, a standard total hip, we cut the neck and replace the ball and the neck with the prosthesis. A resurfacing is we shave the head down and put a cap on it, a metal cap, and then a acetabular cup that is metal on metal. There's no plastic in this. Hip resurfacing started way back when total hips were being developed. They failed until they came up with better designs, better metallurgy. They're marketed to younger adults and say, oh, we're taking less bone away and you can be more active. It's really not true. It's still a prosthesis. It's still going to wear. If you do too much on it, it can still fail. And so it's marketing. It's not really a true, a true statement. It is bone preserving because you're keeping that neck, but in the long run, does that really make a difference? Probably not. And actually, in people who get osteoporotic, women, it can be a detriment because as they get older, they can still get a femoral neck fracture. That little peg doesn't prevent femoral neck fracture, and that's where we become osteoporotic as we get older in this neck and intertrochanteric region. That's where hip fractures in our elderly occur, and so these people still can get neck fractures. Additionally, at the time of surgery, if you don't ream that head just right, you get a little notch on one of these areas, and it's a huge stress riser, and shortly after surgery, people can get a femoral neck fracture. To do the procedure, because you're leaving that big neck in the way to get to the cup, you need more exposure, and it can be very difficult in obese patients to do this procedure. So they have this risk. So it's gone down to suggested for patients under the age of 55 where their bone is stronger, not for women of childbearing age. Part of that's because of the metal on metal and the ions. It's not recommended for anyone with osteoporosis or potential for osteoporosis. Well, all women have potential for osteoporosis. In Missoula, none of us are doing that. None of the docs are doing it. I know it's down south of here. And people have good results, but you have the risks. For what advantage? There's not really any great advantage to do this, in our opinion. Talk about approaches to the hip, the soft tissues and how we do the hip. Again, becomes somewhat of a marketing issue, but there are some advantages. So patients have concerns about after surgery, about pain and discomfort, about recovery, pain medications, how much therapy, how long their hospital stay is going to be, when they can return to normal life, risk of readmittance for surgery, and post-op restrictions. When we did our standard total hips, most hips were done through a posterior approach, through the back of the hip joint, and we had to give patients restrictions. We used to put them in abduction pillows for 6 weeks. We've gone down to just a pillow, but that's how we started. So patients would have to wear these in bed. It was cumbersome. They couldn't roll over very easily. We've gone down to a posterior approach. And so just briefly, the posterior approach, it started out long incision, started out with Charnley way back when, long incision along the kind of posterior side of the buttock. You cut the short external rotators to get into the joint and open the hip capsule through the back of the joint. And then initially they would actually excise the hip capsule, and then years and years ago, now you open it and repair it. So the short external, and they've gone from posterior, the big incisions, to a smaller incision. We don't need all that exposure. You still have to cut those short external rotators to get in the back of the hip. Now there's a lot of talk about anterior approach. An anterior approach is done on a fracture table. You need special equipment to do it. Visualization isn't as good. Some people actually use a C-arm fluoroscopy during surgery to position the cup because you can't see it that well. But you don't cut through any tendons. You're actually going between muscles. And so there has been a lot of talk about anterior approach and a lot of marketing for that. Posterior approach, again, it's tried and true. You can see well. There's lots of experience with it. It's very straightforward. No special equipment is needed. Good visualization to the point where we have to do bigger procedures and revise hips and really see things. We still do it for revision surgeries. You do cut these short external rotator tendons, and you have a risk of posterior dislocation. You weaken the tissues in the back of the hip. You have to do 6 weeks of hip precautions of no internal rotation. So patients are instructed in the hospital not to internally rotate their hip, not to flex and internally rotate, not to flex beyond 90 degrees, so they have to slouch in a chair and be careful getting up from a chair. They have a pillow between their legs in bed. They can't sit cross-legged. They're not terrible. Patients have done them for many years, but in today's society, everybody wants to get up and get going, get out of the hospital. So if we can get rid of these inconveniences, patients always like that. The anterior approach, the approach isn't new. That name I told you, 1925, Smith-Peterson. The anterior approach is also actually called the Smith-Peterson approach. So it's developed a long time ago, but it's new to doing total hips. Lots of marketing, lots of buzz about it. It's supposedly marketed as less painful, and patients get up and move right away. I would say that's pretty common. You can ask your therapist in the room. Our posterior approaches, they're in the hospital 2 days. A lot of them can go home in 1 day. It's not that great. It's more of our methods, getting ideas in patients' heads that they're going to be out of the hospital soon, and pain control, better ability of pain control after surgery. Maybe not so much the approach. But no tendons are cut, just split, or split, I should say. No tendons are cut or split. We just go between muscles and tendons to get an anterior approach. You do need special equipment and retractors and need a special bed. Often docs will use fluoroscopy because they don't visualize it well. It's extremely difficult, again, in obese patients. And you weaken the anterior capsule, so the risk of dislocation is high anterior. So those people have to be careful with extension, putting their hip behind them, and external rotation. And that's how they run a risk there for the first few weeks. And there's been there's been studies, increased risk of nerve damage. The anterior femoral cutaneous nerve runs right very close to the exposure, especially an obese patient. You're putting lots of traction on those areas. You can damage the nerve, and even full femoral nerve palsies have been reported. And additionally, there's talk about, or studies been reported, despite doing an anterior approach, they still have to cut the posterior capsule for visualization, for stability, or for exposure and stiffness. So they're still going in the front, but sometimes cutting the back of the hip joint to make the components work appropriately. I started doing about, a year and a half ago, maybe 2 years, a superior approach. So I'm not going through the front of the hip, I'm not going through the back of the hip, I'm going through the top of the hip capsule and the hip joint. It theoretically is more stable because I'm not disrupting either the anterior or posterior capsule. When I do the procedure, when standardly on anterior and posterior approaches, you take the ball out of the socket to work on the femoral shaft. You dislocate the hip. I never dislocate the hip in this approach. I work on the stem through the femoral head and neck, and then I cut the head off after I have the stem in, and then just remove the head. So I never truly dislocate the hip. I'm not putting those forces on all the other tissues to dislocate the hip. I don't cut any of the tendons of the short external rotators. I still get good visualization of the cup. It's extensile, meaning if I do have a problem, and there are less hip femoral neck fracture, you can sometimes fracture the top of the femur when you're doing cementless total hips. As I said, it's that jam fit. Somebody has weak bone, occasionally you'll get a small crack in the femur. So if I have to expose the hip or the femur more. It's extensile. An anterior approach is difficult to extend farther down the leg. Posterior approach is extensile, but this anterior approach is also extensile. I can go farther down the leg if I need to. It's an easy learning curve. It's very similar to a posterior approach, which we all learn in residency, and so it's very easy to convert one to the other in kind of stepwise fashion over a few hips, kind of say, I'm going to try this, and then you're doing that anterior or the superior approach. I don't need a special operating table. Studies say there's less blood loss, less pain. Again, the less pain is a maybe. No hip restrictions. I don't know if any of our floor therapists are in the room. I haven't told our therapists to do anything different on the floor. I tell the patients when they leave, you don't have to worry about bending over too far. You don't have to put a pillow between your legs. And we test the hip, how stable they are in surgery. And sometimes I'll say, don't worry about internal rotation. Other times I will say, I'd rather be conservative than have somebody dislocate. I might say, still follow those internal rotation precautions. But we don't have to put those patients on hip restrictions, and the patients really like that. From my standpoint, the anatomy and the anatomic landmarks are similar to a posterior approach. It's a small learning curve. I can still see the acetabulum well, where anterior approach, that sometimes isn't the case. I don't dislocate the hip because that bone is intact as I'm working on the femur. I have less chance of femur fracture during surgery, lower readmission rates as well in this approach. So little diagrams. Superior incision is small. I don't call this minimally invasive. I don't like that term. I'll make the incision as big as I need to do the procedure and do it well. The traditional total hip incision is 8 to 10 inches. I would say now traditional incision is about 6 inches for a posterior approach, or that mini posterior approach. So it's smaller, and we do make a little small incision just below this incision for one of our guides to do a superior approach. And I'm not cutting these external rotators. I'm going through up above them through the hip joint up here, not through the posterior hip. Study-wise, this is not my study, but a recent study. Mean length of stay for superior approach, 1.6 days versus anterior almost 3 days, posterior 3.49. Now a lot of my partners and people do posterior approach, and they're out the door at the same time as my superior approach. So this doc study here in Missoula, I would say they're pretty comparable versus a superior approach versus a posterior approach. Mean operating time is a little less by the surgeon. Blood loss was less. Complication rate was less. Look at direct anterior, 13% complication, posterior 11%. This anterior supine intramuscular was known as an anterior lateral approach. It's done a lot in Europe. It's not done so much in the U.S. We shoot for that 40-degree cup inclination. This doc got it often. They're not that different, and to be honest, a couple of degrees really doesn't make a difference. No special table required, no restrictions. Posterior approach, there's abduction pillows. Discharge home, more people going home than to skilled nursing facilities or inpatient rehab facilities with this superior approach. Infection prophylaxis, George can probably speak much more about this than I can, but today we do MRSA screenings on our patients with a nasal swab. If their nasal swab is positive, we treat them with chlorhexidine showers for 5 days. They get Bactroban ointment in their nose twice a day for 5 days before surgery and 3 days after. If it's negative, they do a chlorhexidine shower the night before and the morning of. All patients get chlorhexidine wipes here at St. Pat's in pre-op. We make sure their antibiotics are given no sooner than 1 hour prior to incision, and we typically use Ancef, 2 grams in patients, 3 grams if they're over 120 kilograms. They get 2 grams every 8 hours for 2 doses postoperatively. If they're penicillin allergic or cephalosporin allergic, you can use clindamycin or vancomycin. If they're MRSA positive, they get Ansep and vancomycin. And vancomycin doesn't treat standard Staph aureus as well as Ansep. It does treat the coag-negative staph and MRSA, but better than Ansep, but not the standard staph. Normothermia has become very important in the operating room, so they have warming blankets on during surgery to keep their temperature normal. Found if you let the patient get cold, their infection rates go up. So we try to keep the patient normothermic. And our surgical prep in surgery, we often use more than one antibacterial, and it's not just bactericidal, but bacteriostatic. Stuck on static. Betadine is bacterial static more than cidal, and so we use chlorhexidine. We often use, in addition to that, a chlorhexidine scrub in surgery, alcohol or iodine, or chloroprep, which is another chlorhexidine preparation with alcohol. So they get the scrub. In my cases, they get the scrub, then they get alcohol, and then they get chloroprep on top of it. And the chloroprep, actually, we don't wipe it off at the end. It has bactericidal properties that last longer as long as it's on the skin, so we leave it there. When we're done with surgery, we put on a waterproof, silver-impregnated dressing that stays on for 5 to 7 days, and the silver also is bactericidal. So these dressings came out of the military, and they'll actually put these on in the battlefield and pack wounds with these silver-impregnated dressings, and it decreases infection rates greatly in open wounds. So they moved it on to putting on the dressings. DVT prophylaxis today, mechanical and chemical, so patients get TED hose, knee-high TED hose, either sequential pneumatic pumps or foot pumps. Chemical prophylaxis with Lovenox or oral factor 10 inhibitors such as Xarelto for total hips. Aspirin has been approved by the Centers of Medicare. They're really following us closely. It's over the last year or two, it's been approved at 325 milligrams twice a day. But most of us are leery to use aspirin on total hips, using it on total knees, but not hips yet. I'm using Xarelto and sending patients home for 2 weeks on Xarelto. Aspirin is common for knees. If I do put people on aspirin, I'm also putting them on some type of H2 blocker or Pepsid or proton pump inhibitor. I did have one woman who got a perforated peptic ulcer after about a week and a half on aspirin. So they all have their risks. They all have their risks. Pain management today is a multimodal approach. Pre-op education is the real key. If we tell patients, you're going to get up the day of surgery, we're going to move you, you're going to be out of the hospital in 2 days, it makes all the difference in the world. If you don't tell them that, they're thinking, oh, I thought I'd be going home Thursday, do surgery on Monday. Oh, I thought I'd go home Friday. Now you're going home Wednesday. Be prepared, be ready. People are doing outpatient total hips nowadays. We've talked about it. We are not ready to go there yet. We're not sure there's an advantage. Cost savings maybe, but risks, a lot higher readmission rates. So we're not going that direction. We do the anesthetic is most commonly a spinal with some type of sedation or light general with an LMA. Patients are breathing on their own, so with that light general, they don't have to make it as deep. We often give them a long-acting opioid in pre-op, such as OxyContin. Personally, I don't do it on elderly patients. We seem to have more problems with confusion and sedation if we do that. So if they're under 65, we'll do it, but over 65, I don't typically. We use a pain cocktail in surgery, which is injected at the end of the procedure into the soft tissue. So I inject it into the hip capsule, I inject it into the fascia and the muscle that we're going through. I still have to split the gluteus maximus muscle for that superior approach. I didn't mention that. We don't cut it, but we do split through it for a short distance. So we inject that, and it's 0.5% marcaine, epinephrine, clonidine, and toradol, and some normal saline. And these patients get good 36 hours of pain relief. And our total knees, I mean, works wonderfully on our total knees, which usually are very painful, more painful procedures than total hips. And these patients are taking very little narcotic. They have very little pain for those 36 hours. I mean, you come up and see them. Some people are taking no pain medication for the first 36 hours. And it's the quantity that makes it last so long. And I still, to this day, have not been able to get anybody to tell me what the quantity does to make the Marcaine last that long. I've talked to pharmacists, I've talked to other docs, nobody can tell me. But it's the clonidine that's the key there that makes it last 36 hours. There is a liposomal lidocaine, and the lidocaine is kind of packaged in these little liposomal spheres, and it's long-acting up to 3 days, but it's expensive. So we've not used it here, trying to keep our costs down. Early use of oral opioids, we get them off the IV medications as soon as we can. We add acetaminophen. And here at St. Pat's and across town in a lot of places, our pharmacists are very helpful. There's a pain team. They come around once, twice a day, interview the patients, they talk to them about their pain levels, and they manage their pain more than we are these days. And it keeps them very comfortable. We're using Robaxin a lot as a muscle relaxant. It seems to help with a lot of the muscle pain the patients are getting. We don't really typically use Lyrica here, but Lyrica has been shown to be effective in postoperative pain management, and Celebrex is also used. Celebrex is a COX-2 anti-inflammatory, doesn't interfere with their anticoagulation, and so it's often used preoperatively as well, and then postoperatively. And getting the patients up right away, getting them is helpful. When I started 25 years ago, hospital length of stay for a total hip was 5 to 7 days. Nowadays, we're down to 2 or less than 2 days. Patients are going home. You know, if they're operating in the afternoon on Monday, they're going home sometimes on Monday morning. So less than 2 days. And some patients ask to go home day 1, and we're like, well, we don't want you to bounce back. Let's keep it. Thanks very much. Lots of things there.
Push the red button. Just push it once and now talk.
No, the light's not on. Fix it.
Okay, I'm just going to ask, you didn't mention use of NSAID like Aleve, Tylenol for post-op pain?
We don't use it while they're anticoagulated. Too much bleeding just interferes with their anticoagulation.
And any role of Cymbalta in post-op pain?
Not that I've seen reported. You know, I know Cymbalta is used for chronic pain. I don't know that, personally, I don't know how quickly Cymbalta works. You know, so you need to repeat the question. Oh, I'm sorry, I'll repeat the question. Sure. Yeah.
I have a question about the timeline of the various prostheses that you went through.
Mm-hmm.
So you put some dates, but not a lot of dates up there.
Yeah.
So I'm just curious and I know I don't know if anybody's tracked this, but if you could give us an estimate of the universe of people out there now who have had total hips, they're still alive, what percent are the metal on metal, the ceramic on?
Oh, no, I don't know the numbers.
What would you guess?
I would say a majority of patients are still metal on plastic. If you look at the numbers between about 2000, maybe say 2008, well, even before that, probably 2005 to 2013, the number of metal on metal hips was increasing to the point about 2013 when there was a sudden drop. But percentage-wise, I'd probably say nationwide it still is probably still metal on plastic. More were done than metal on metal, but that's a guess.
Are any of you here in town doing the anterior approach?
Nobody in town is doing the anterior approach. We've talked about it. It's just, you know, the big thing with total hip is long-term. You're not looking at short-term results. If a patient moves, and safety, if a patient moves a little faster early on, does that really make a difference 20 years from now when you want that hip to still last? And it doesn't. And so why change something that works? We're relatively conservative when we make changes in our procedures. Why change something that works, that's tried and true? There's not a huge advantage long-term for it. Yes, there may be a little advantage short-term, up faster, but again, I kind of went to that superior approach because it's very similar to the posterior approach. There are some advantages. I think it's even more stable than the anterior approach because I'm not disrupting the anterior capsule. And from that superior approach to the anterior approach, I don't see a big difference.
And does your group track its own results and you share that with your non-surgical colleagues?
We have not yet. St. Pat's is starting a hip registry. Is Betsy in the crowd? Oh, Betsy Weber is kind of heading that up, but all of Providence is beginning a hip registry for all of their hospitals, or a total joint registry, I should say. I think that will start within the next 6 months. And so then we'll have the ability to do that.
So it's hospital-based, not practice.
It will be done by the hospital, but it will have individual information, physician and information and component information. They will be tracking all that. It's very difficult to compile those numbers. It takes, you're going to have to employ somebody full-time to do that. That's a resource we don't have. But the hospital is, for Providence has decided to put that in. I believe community is doing the same too. They are using third party. I'm not sure about that. Yes?
That pain control cocktail that you're introducing at the end of surgery, are you putting it in the wound before you close? Are you injecting it through the skin or through the muscle? Or
the question was, with the pain cocktail, how are we putting that in? How are we injecting it? When we're done with the procedure, kind of from inside out, I inject the tissue. So the first thing I inject is the hip capsule. Then I close the capsule. I inject the capsule deep in the wound, close the capsule, inject the tissue that I just closed, the superior portion of the capsule. Then close the fascia, inject the fascia and the muscle. I don't do it through the skin or the subcutaneous tissue because of that long-acting epinephrine and marcaine. It actually can cause some skin loss. I saw that once on a knee. It got injected close to the skin and skin blistered because it basically made the skin necrotic. So for that long, so I don't do that.
does it affect the infection rate?
No, if anything, it might help. The marcaine is bactericidal, so it may be beneficial, but no study has been shown to say it increases infection.
And do you know the infection rate of your group?
I don't know if you look at our group total of the infection rate at St. Pat's for total joints is below the what the average is for all of Providence, and it is, I believe, below nationwide scales. We quote 1%, and I think average in nationwide is 1.6%. Don't hold me to those numbers.
What about just a light nerve patch?
Not tried it. Most of the patient's pain is, with the pain cocktail in place, most of their pain is intramuscular. They complain of butt pain more than anything, some groin pain. But again, we're putting a sterile dressing on in surgery, so we have to keep the wound sterile and keep it, at least initially keep it dry.
Gary, you were talking about impingement.
Yes.
What are you trying to correct? Is it just the angle of the acetabulum, so they're not getting impingement?
When in a total hip or just treating hip impingement like
Well, you
arthroscopic?
mentioned that they are
reason for replacement?
Cam impingement, there's two types of impingement, cam impingement and pincer impingement, or a combination of the two. They're both, think of it as the head being too big for the socket or the socket being too small for the head. It depends how you look at it. But essentially, somebody who has impingement, their head and neck bang up against the edge of their acetabulum. And so the procedure, and they often get labral tears of their hip. So the procedure for that is to repair the torn labrum and remove bone usually on the femoral head and neck that's banging up against the acetabulum. That's the hip preserving hip arthroscopy for that. It can be done open too, but you're removing that bone that's impinging or jamming up against the socket. You're not changing the shape of the socket. The work's done on the femoral neck. Yes, sir.
Is there a level of osteoporosis that you can't do these total hips, like a certain T-score where you just say?
No. I'm sorry. The question was, is there a level of osteoporosis that we couldn't do a total hip on? The answer is, I can't say I've seen or anybody that I know has seen it. We don't look at the T-scores. We might look at the X-ray and say, boy, they're pretty osteoporotic. And you might look at somebody who's extremely osteoporotic and say, I think this patient would do better with a cemented stem than a press-fit stem because their potential to heal that is pretty low. But osteoporotic people still heal fractures, and we're asking the bone to do the same thing. So it would be very rare. We treat the bone more gently, but it's pretty rare that we would not use a cementless stem. If we're doing it for somebody who has a tumor in their acetabular region, and it's metastatic, maybe a metastatic tumor, length of life is always a question. Occasionally you'll cement a cup in for those folks because their potential to heal, they're getting radiation, potential to heal and stabilize that cup with bone healing is pretty low, so you might cement to get that immediate fixation. That cemented cup is going to last their lifetime. Yes.
Let's make a coffee, I'm full of questions.
Yeah.
So I've often wondered this over the years. If you had, what's your take on looking at a DEXA score and your feel of the bone surgery? Which of the two are the best, or do they correlate? Do you have an opinion?
They correlate, certainly. I'm sorry. The question was, do we get a feel if the DEXA scan results and the scores correlate to how we examine the bone or get a feel for what the bone is like at surgery? They certainly do correlate. We probably look more at the radiograph than the DEXA numbers for surgery, and it's kind of a rule of thumb that if you see an osteoporotic bone on an X-ray, they've lost about 30% of their calcification of the bone. So it's kind of we look more at the radiograph than we do at the DEXA numbers. One of the things our orthopedic academy has said is we should own the bone, and orthopedic surgeons should take more responsibility in preventing osteoporosis and treating osteoporosis. So I think there's been a big push for that. We're starting to adopt that in our group. We have a PA now who is going to really concentrate on that. Pam Peterson worked with Dave Allbacher, used to do that in his group. Pam has now moved on to do teaching at a nurse practitioner, and so one of our PAs has taken that on. And so we're going to kind of start having some protocols in the office to refer patients to, it's Joan Bond Deschamps, to her, for our hip fractures and our wrist fractures. But we also will say, do you have a primary care physician? We don't want to take that away from primary care docs either. Yes?
We all know people and patients who have had their lives changed by having total hip. No question. For some people, it's great. How do you help patients discern whether they need one, whether now's the time? So
let's say a patient comes in and says, I have hip pain, and Certainly hip pain can be very many things, but we do an evaluation, they have an arthritic hip, and of course on a radiograph that arthritis could be very variable, could be severe, it could be mild. I always train to treat the patient, you don't treat the x-ray, first of all. And you go through an evaluation, you see how much it's affecting their lives. Certainly try conservative measures first, anti-inflammatories, weight loss. Physical therapy, maybe the physical therapist would disagree, but physical therapy hasn't been shown to affect patients' hip pain very much with an arthritic hip or affect their range of motion once they get stiff. You can get a little gain, but usually not very much. Strengthening, if they're extremely weak, you might change that a little bit, but once they've developed their groin and buttock pain, it's hard to get therapy hard to make that vanish. Anti-inflammatories, you can do a steroid injection in the hip, which is temporary. It has to be done under guidance, like a knee. We just can easily have you sit down and put a cortisone shot in your knee, but a hip and joint injection has to be done under fluoroscopic or ultrasound guidance. So it's a little more involved, but it can provide relief for a short time. And that's really all we have for hips, unfortunately. Use a cane in the opposite hand. And so, when I was in training, and the docs often would say, you'll know when you need your hip replaced. You have arthritis, you'll be back, you'll know when you need your hip replaced. I never thought that was a very good answer. I thought that was, the patients look at you like, how will I know? What do you mean I'll know? And so I never thought it was very good. So I kind of tell patients, when that hip is interfering with your life, your vocations, and your avocations, if you can't work because of your hip, or you can't have, you're limiting your lifestyle because of your hip enough, that the benefits of getting rid of the pain outweigh the risks and hassles of surgery. And those are the words I use to my patients. When the benefit of having this done outweighs your risks and hassle of going through surgery, then it's time to have this done. And, I send many patients out on anti-inflammatories and say, come back, I'll see them say, come back in 6 weeks and let's see how you're doing. And often they'll come back and say, hey, I'm pretty good, but 6 months later, they're back and saying, this isn't so good. So I do leave it up. I never tell a patient, you need to have your hip replaced today or now. I never say that. I should say never is never. I've seen a terrible destroyed hip and say, and I will say anti-inflammatories are not going to help you. You see people with, their femoral head is worn away, it's almost gone. I say that's not going to help. I think the only thing that's going to help you is a hip replacement. But I don't make that decision for them. I say, here are the risks, here's the benefits, this is what you can expect, this is what you can do on a total hip. You can, we tell patients you can walk and hike and bike and golf and swim as much as you want. In Montana, you can cross-country ski, you can downhill ski with, stay off the bumps, and, somebody's going to ski, 200 days a year, I might say, maybe not the best for your hip, but people don't ski 200 days a year, they ski 10 days a year. And 10 days of skiing is not too much force on hip replacement. I also tell them when they have that, you do run a higher risk of a dislocation than the average person, and you run a risk of periprosthetic fracture if you're going to fall. So you have to warn them about it. It's not perfect. But getting back to the original question, I do leave it up to the patient, but I give them pros and cons, and I don't say, you'll know. I say, when it interferes enough with your life. Because, when you say avocations, what makes life fun? Well, if your idea is you go for a 2-mile walk every day and that's your enjoyment, that's how you get your stress relief, you can't do that anymore. It may be time to have your hip replaced. If you're climbing the M and you can't do that anymore, maybe you can walk around fine and you can make it through the grocery store and you can, do everything, but you can't go up the M, and your goal is to go up the M, maybe it's time to have your hip replaced. That's your decision. Yes, Anna?
In light of that, does non-use causing muscle atrophy play a role in your advice to people? In other words, is the rehab after, I'm thinking actually more knees than hips, but I'm asking about hips. If people aren't doing things, they're gonna lose muscle.
Correct.
So is the rehab worse, and does that play a role in your advice?
If they're significantly weak, we'll do prehab, call it, certainly for total knees, much more than total hips. You know, the muscles around your hip are large, they're kind of those slow reaction, large fibers, muscles. They're, you stand, your gluteal muscles are always firing. So it's the patients who have trouble getting up from a chair, can't climb up any stairs. They have to be pretty bad. Those people will send to PT first. Or they have extremely poor balance, we'll send to PT first. They tend to be very, the octogenarians and the very sick 70-year-olds, not the standard 73-year-old who is still running their household and getting around and doing their grocery shopping but having pain. Those ones knees are different. Knees prehab makes a huge difference in their recovery. Hips, now most patients we're not even sending to outpatient PT after, we're letting them do it on their own, reevaluating if they're still a little slow to send PT. Yes, sir.
I've heard it said that only orthopedists want to do both hips at the same time because they don't want to miss work. Is there any indication for doing both hips?
There are, and I've done a few. I mean, every few years. Actually, just did one this week. And it was at the patient's request. He had only so much time to be off work. He was a young, low 50s, healthy gentleman. It's difficult rehab. It's a lot more blood loss, some little higher perioperative risk factors, bigger risk of a blood clot if they have cardiac issues, bigger risk of MIs. So it's rare. Somebody who's a bad rheumatoid, where one hip is just as bad as the other and they can barely walk, these people can't get out of a wheelchair because of their hips, good idea to do both at the same time if they're strong enough physically to tolerate. You have to always wait.
It's hard to recommend.
I would rarely recommend. Like I said, in 25 years, I've probably done, I can think of 3, maybe 4. So it's rare. And I don't like doing bilateral knees. I mean, I've done them, certainly done more of those than hips, but I don't like doing it. It's a difficult rehab for the patient. And, some patients say, some of them do, teachers, I only have the summer to get this done. I need to get them done. And they're young and healthy, and they can tolerate it. And they'll tell you they're miserable for the first few weeks, just miserable, because they don't have a good leg to stand on. All right.
Thank you.
You're welcome. Thank you.